You're listening to Beyond the Endpoint, a podcast from the Duke Clinical Research Institute. In this series, we're demystifying clinical research and answering your pressing questions about health and healthcare. You can find our full episodes at dcri.org/BTE.
When it comes to health news in 2025, it's hard not to mention the rapidly evolving world of GLP-1s. These medications were originally developed to treat diabetes, but quickly gained attention for their benefits in cardiovascular health and weight management. And many in the scientific community believe that that's just the beginning. Ongoing research is exploring how GLP-1 agonists can help treat a wide range of conditions, from sleep apnea and kidney disease to liver disease, substance use, Alzheimer's, Parkinson's, and more. Because of their potential to impact so many areas of health, we are launching a new series called GLP-1s, Diabetes, Obesity, and Beyond. We'll be talking with experts about what makes these drugs so groundbreaking, how they're transforming obesity treatment, and where they might be headed next. Hi, I'm Dr. Emily O'Brien, a population health researcher at the Duke Clinical Research Institute, and I'm joined by my colleague, Dr. Manesh Patel, head of cardiology at Duke and a fellow DCRI faculty member.
Yeah, thanks, Emily. We really are excited to kick off this three-part series. We'll look at how GLP-1s first made headlines, their growing role in obesity treatment, and how they've become powerful tools in many other areas of medicine. In this first episode, Emily sat down with Jennifer Norris, a physician assistant at the Duke Center for Metabolic and Weight Loss Surgery. Jennifer works closely with patients who are considering or have undergone weight loss surgery. She describes GLP-1s as a powerful addition to her toolkit alongside the surgery, diet, and lifestyle changes to help patients reach their goals.
Jenny, thank you so much for being here with us today. Let's go back to the beginning. So what drew you to the field of medicine, and how did you end up in this field of obesity treatment? I know you started in urgent care and then eventually made a shift to bariatric surgery and chronic weight management, which we'll talk about in a little bit, but take us on that journey.
Yeah, so I was always interested in the sciences and in medicine, which led me into PA school. When I first started out as a physician assistant, I started in urgent care, and that just was not the best fit for me personally, because patients would come in with a problem, we'd patch them up, and then we'd send them on their way. And what I really like about what I do now is getting to know my patients and being a part of their journey and involved in their journey, and being able to celebrate their success and wins and victories, and also being there for them if they have some setbacks.
Yeah, I think that's going to be a really important part of our conversation today. And people don't often think of obesity as a chronic condition, but it really is. And I'd love to hear more about your current role and kind of how that mindset sort of comes out in, say, your interactions with patients and families, or even with the colleagues that you work with.
Yeah, 100%. I think pretty recently, especially in terms of the medical field, obesity's been accepted as a chronic disease and thought of as a chronic disease. And that's really important because it really, truly is. It is just so multimodal. There's so many things that go into this disease. For the longest time, I think people thought, oh, it's exercise, it's diet, it's behaviors. And certainly that plays a role, but even more so, it's genetics, it's biology, it's environment, it's comorbidities, and it's just certain situations that kind of lead you down the path of obesity. So right now, in my current role, I'm a physician assistant with the Department of Minimally Invasive Surgery. And so we offer all treatment options for obesity, from behavior intervention to medical intervention to surgical intervention. And we really do approach obesity as a chronic disease and a complex disease. It's definitely not one size fits all when you're treating obesity. And sometimes you need more than one treatment option.
Yeah, I really like what you said about the complexity of the condition, which it sounds like your practice is doing a good job of reflecting in the diversity of the team members who are involved in the care and in all the options that one might use to sort of help manage this. It also makes me think of like how differently people sort of view this condition and like how much misinformation there is out there about this, that it's just about willpower or it's as simple as like calories in, calories out, or maybe on the other side that like it's totally genetic. So if you have overweight family members, like that's your destiny too. My guess is you've heard all of these and more over the years. Is there a certain like sort of number one myth that just drives you nuts or other misconceptions that you kind of always find yourself correcting?
Yeah, I think the biggest ones, and you kind of touched on it already, but it's behavior driven, right? Like eat less, move more. And that's just not the case at all. It is so much more complicated than that. And then I think the other misconception would be that it's a one size fits all treatment, right? Like go on this diet, exercise more, try these medications. And it's just every stage of a journey is going to be different. And that's why I think it's really important to find a specialist that you can work with and can help guide you through the journey.
Yeah, and I imagine it's a super interesting time to be working in this space. I mean, I just think about how much has changed in nutrition and the, food pyramid on the back of my Lucky Charms box that I read as a kid that like encouraged us to have, as long as you have, your 9 slices of bread, no fat at all, you are good. Now that would get you like kicked out of the room at a nutrition meeting. But tell us a bit about the shifts that you've seen, sort of reflecting back from when you first started. You were well prepared with what you learned in school and sort of got going in this field. And things have probably changed a lot in terms of the attitudes. How has that looked?
Absolutely. I mean, one good thing is the attitudes, it is starting to change that obesity is being accepted as a chronic disease. And I think it's also the approaches are becoming a lot more multimodal. And we have better tools in our toolbox than we did 10 years ago. The surgical interventions are advancing. Most definitely, the medical interventions are advancing. When I first started doing this 9 years ago, it was right around the time that Saxenda, the Gen 1 GLP-1 came out, and just kind of growing in this field as the medications have been advancing and evolving has been really cool. So better tools in our toolbox. I think more education and anti-stigma advocacy for sure. And a greater emphasis on it's not just about weight and appearance, it's about health.
Let's talk for a minute about the distinction between health and weight. And there's probably enough here to fill many, many hours of discussion. But tell me how you think about this. So I know this is controversial and there are lots of perspectives about this issue. And from my naive sort of research standpoint, what I hear a lot is overweight and obesity, we know from the epidemiologic data, are a major risk factor for cardiovascular disease. And from that perspective, this is something that we should intervene on. On the flip side, you can't Google BMI without seeing some paper about how this is a crappy measure of health and it oversimplifies the story. And it's possible to be, say, a weightlifter with a BMI that classifies you as overweight, but you're, way healthier than somebody who's pack-a-day smoker with a BMI of 23, who's like not been to the gym in 3 decades. So what narratives do you think are most helpful for people as they think about this health and weight sort of dichotomy?
Yeah, it's tricky for sure. And in my practice, I like to put the power back to the patient because you're right, BMI is old school and it's not a great measure, but even like that's what insurance companies use to determine if you qualify for weight loss surgery or a weight loss medication. We're just kind of stuck with it still. So I like to preface that like, hey, here's what we know about BMI. It's not great. Let's not put all our eggs in this basket. Let's focus on what your personal goals are. And sometimes a patient does come in with a weight goal, and that's great. That's totally fine. I can support that. But I think more often, my preference is when they come in with health goals, whether that be getting off some blood pressure or diabetes medications, finally getting their hip replaced, keeping up with their kids or their grandkids, having more energy. Those are the kinds of health goals that I try to set with patients to kind of stay away from a scale goal.
Yeah, and I imagine that part of the conversation is like, what's the balance between focusing on this target, which might sort of, keep you accountable, encourage you to stay on the medication, but also recognizing that what you're trying to get to, regardless of that number, is like better quality of life. I got to ask, like, did you know that it was this complex? Did you like the complexity? Was that why you were sort of drawn to it? I mean, it is really complex.
Oh, I know. I have to be honest. I did not, when I first started, realize, but it certainly keeps things interesting and makes every day different than the last.
It's so amazing because it seems like such an uphill battle still in terms of the stigma and the public perception. I was randomly on a social media platform yesterday, and the big story now, at least for my feed, is someone who came out and said, if you're over 200 pounds, like Pilates is not for you. And it was amazing to see all of these people who like know Pilates and like even have done a lot of the science on physical activity and particularly Pilates and benefit for health, who said like, the whole point of that particular form of exercise was to help rehabilitate soldiers. And like by definition, it is inclusive and it's something that can make your body healthy and strong, even if you don't fit this sort of classic, heavily marketed image of what we think the Pilates practitioner looks like. And so it's just so striking to me that like, yes, we're getting better at recognizing that health doesn't always look the same for everybody. At the same time, there's still so much misperception in this space. And I imagine a lot of your role is also sort of educating people and like correcting that, which I'm sure is really gratifying.
This is Beyond the Endpoint, a podcast where we bring personal and expert perspectives on healthcare and clinical research to the casual listener. Stay tuned after the interview for a breakdown with the hosts. They'll talk through key takeaways and what this week's topic means for you.
So you mentioned that, obviously there's no one-size-fits-all approach. One form of treatment, as you know, has been everywhere in the headlines. So you literally cannot pick up your phone and look at the news without seeing something about GLP-1s, Ozempic, tirzepatide. Lots of them are available and increasing number of treatments. We've talked on previous episodes about the different modalities that are now coming onto the market, not just injectables, but oral medications that hope to kind of offer the same benefits. So tell me your thoughts. Are they game changers in your practice?
Absolutely. I absolutely think they are. For a long time, we really didn't have, it went from behavior intervention to surgery. So this has kind of been a great bridge for people that are maybe not 100% ready for surgery, but definitely wanting an intervention. And they are definitely a game changer in the field. We never had a medication that worked this well until this class of medication came out. So, on average, people are losing about 20% of their total body weight, which is fantastic. They're pretty well tolerated. I think in the media, you definitely hear and see some stories of side effects. And that's why it's really important to work with someone who's familiar with obesity medicine, who has some education on the field to help guide you through the side effects and taper correctly and help you be successful with it.
Yeah, I remember when I first saw the results from the early trials that were designed to measure weight loss with semaglutide, and I was just so blown away by the effectiveness. It's not an area where I spend a ton of my time, but I sort of keep on top of the weight loss interventions a bit in the literature. And I didn't really know much about this medication at all. And I was just so shocked that like, wow, this is way more effective than certainly any other diet-based intervention that we've tried, for years and years over thousands of patients and hundreds of different studies, maybe thousands of different studies. And I'm wondering, like, are you seeing, and this is to me so interesting because it's not, I think, what typically happens in medicine. I think often patients are being educated about the effectiveness of therapies like in clinic. I'm wondering if you're seeing that flipped a little bit here, where people sort of walk in the door and they're expecting this sort of magic bullet that like is going to take all of this away, and not just the physical side, but also the psychological struggle and the stigma. And for some people, issues that have sort of built up over their whole lives. And I have a couple who I'm friends with who are both on a GLP medication for weight loss. And it's amazing that like they've had different responses to the same therapy. Have you seen that kind of variation, or is your experience more consistent with like, oh, these are working for everybody and like people are happy with it, and that does turn out to be a magic bullet?
No, 100%. I certainly have patients that it takes off and they're super responders. They don't have any side effects. Life is good. Their journey is moving forward. But I do have patients who get started on it and it's slow out the gate. And it's frustrating for sure, because I think if you're going into it and you're thinking, finally, there's an option for me, this is going to be it. And then you still continue to struggle. That's so frustrating. And that really is the disease of obesity. But it is nice now that there are different molecules coming out. We have semaglutide, we have tirzepatide. So that's one thing I'll talk about a lot, is maybe switching from one to the other if one doesn't work for you. And, again, multimodal approach, changing up diet habits, changing up exercise routine, more seriously, perhaps thinking about weight loss surgery.
Yeah. And just to sort of honor the complexity here, we've talked about all the treatment options. And so you're thinking about what's out there. You're thinking about what somebody's tried in the past. You're thinking about their medical history and also their preferences. And then we layer on all the issues with access and payment that are real barriers to what people can actually pursue in terms of their treatment. So please tell me it's better than it seems like it is.
It's not. It's not. It is so frustrating. They're so expensive and a lot of insurance plans still aren't covering them. Even more frustrating is when an insurance plan does cover it for some time and then they decide they're not going to cover it anymore. Because what we are learning about these medications is it's really best if it's a long-term treatment. We're seeing in most cases when the medication is stopped, there's some degree of weight return. So it's frustrating. It's a great treatment, but it's an expensive treatment. And, the insurance coverage is questionable. Frustrating landscape for sure.
Is the landscape for reimbursement really different for bariatric surgery versus GLPs?
Yeah, that's a good question. So I think most insurance plans cover weight loss surgery. I think probably what the insurance companies think is it's a one-time payment versus for the medication, a monthly forever payment. Has to be my guess.
Right. Yes. And it'll be interesting to see as, we have more data about the additional benefits of these therapies in terms of cardiovascular risk reduction,
kidney disease, liver disease, addiction, just endless. Yeah.
I think it's true with a lot of therapies that they first come out and when they're expensive and the manufacturers are trying to recoup their R&D costs and really sort of ride the wave, it takes a lot of data, I think, and probably a lot of advocacy to convince payers that if you don't have to pay for the heart attack treatment or the stroke treatment or the addiction treatment down the line, financially, this could be a good bet. But that's not something that seems to have quite taken hold yet.
No. Hopefully in the future, and hopefully the cost of the medications goes down. There's more in the pipeline, so competition is a great thing. Hopefully, as more come out over the next few years, that will help availability for the ones that are out now.
All right. I also just got to ask, as an expert in this space, when you see things on social media like this is nature's Ozempic, do you just hurl your phone across the room?
Gosh,
Do you
yes.
scream? Okay.
Scream into the abyss, totally. I have so many patients that ask me about them, and it's not research, it's not scientifically backed, no matter how many different studies they're quoting. Yeah, it's frustrating. And it's a money-making industry, so it's a shame that people, I think, are taking advantage of a really great treatment option and trying to monetize on it.
So you mentioned that, for some people, there's this like really kind of tragic sort of fork in the road for them when they lose insurance coverage, or compounded medications are no longer available for them, where they've, seen some good progress and then unfortunately you're no longer able to have, get access to the therapy. I want to talk about the folks who do really well and reach their goal weight and are thinking about maintenance. First of all, are you seeing a lot of those people? And if so, how do you advise them? Is the goal to kind of get them off therapy and transition them to lifestyle and hope that all goes well? Or
Yes, I think that is such a personalized approach. Every patient's journey is different. I certainly have some patients that hit maintenance and they're like, no, I want to stay on this medication. It is working well. I'm tolerating it well. I am happier than ever. And maintenance for me is going to look like staying on the medication. And I think that's what most of the literature supports, is that sort of journey. But I certainly have other patients who, are like, I'm not crazy about being on a medication for life. Let me try to get off of it. That approach, I usually step down on the medication. So we taper the medication back down. And I think really leaning in on behavior intervention and being sure that you're building or maintaining as much kind of muscle and strength as you can. So strength training, a high protein diet, and then kind of tapering off the medication slowly. Because inevitably, for a lot of people, what we see happen is when the medication comes off, the food noise comes back, the cravings come back, the hunger comes back. And absolutely, I've had patients successfully come off and maintain, but that is the minority.
yeah, it seems like an area where there's a ton of research interest about, like, okay, well, there's truly equipoise. So if we take one of these different approaches, like, what can we expect? And importantly, how does the response to coming off therapy and different approaches to maintenance, how does that differ for different people? And can we learn something about what to recommend for certain people who, may benefit from one approach versus another? So I'd be curious to hear your thoughts. Where do you think obesity medicine is heading next? I mean, this has been a crazy time for the field over the past several years. And I mean, I think it's fair to say it's been revolutionized by these therapies. It sounds like, based on what you've said earlier, bariatric surgery is not going away. Lifestyle and behavior interventions are not going away. GLPs are just a tool in the toolbox for now. But what are you excited about on the horizon?
Yeah, there are some medications in the pipeline. I think a few are getting pretty close. They're in phase 3, which means they are approaching being ready to submit to the FDA for approval. In medicine, all of that kind of still means nothing because it does take quite a while to get there. But there are some new medications that have components of a GLP-1 and a GIP and even some triple mechanism. So even another targeted hormone that are looking really promising and promoting even a little bit more weight loss than what we have out now. So there's definitely new medications in the pipeline and more research being done every day. What I'm most excited for is the more treatments that come out, hopefully that drives down cost and makes some of these current treatments available to more people. Or for, like your friend who maybe the GLP-1 hasn't been a slam dunk. Maybe one of these new options, new modalities will finally click and help for her.
Yeah, I mean, I think I'll say as a researcher, like, that's the area that I think needs the most additional research. And it makes sense that, we've seen the uptake in these medications that work so well as like kind of a universal approach for everybody. But that's just one anecdote. But I think what we are starting to see in the data is like, yeah, we can see variation in responses. And maybe that's something to really study and try to understand better so that, like you said, we have options to offer to everyone that give them a chance at success if something that they've already tried doesn't work. All right. So fast forward 10 years, what do you think your practice will look like?
Oh man, that's such a good question. I hope it will look like patients who have been hoping to get on a GLP-1 or get better control of their disease obesity have access and availability. I hope that we will continue, and I know we will, continue to treat obesity as a chronic disease and just continuing to expand that toolbox and expand availability and coverage for obesity treatment.
Yeah, it's, I think, such an important perspective from somebody who's really on the front lines with this, that the additional therapies being made available, like that's important. But the reason that you're excited about them is like it will mean more access for more people, which really speaks to a lot of, I think, the growing focus on like implementation science and health policy, and how even if we have a therapy that is perfect in clinical trials, if we can't get it to people, then there's no translation of that work. All right. So last question. If listeners walk away remembering just one thing from our conversation today, what should it be?
For sure, like we've talked about, obesity is a chronic disease and it's a difficult disease to treat. And we have finally some good tools in our toolbox and a few new options. So don't be afraid to ask for help. Don't feel like you're a failure if you're asking for help. This is a disease and it's a hard one to manage. And I would just hope that people would feel comfortable, feel like they can open up and talk about it and talk about goals, because it is a sensitive subject for sure.
Well, Jenny, I'd like to thank you for such an honest and insightful conversation. I mean, your work is so critical, and I think you're really part of such an important movement to change the way that we think about obesity. I know it feels like one patient at a time, probably in your practice, but it's a huge impact at the population level. So as a populational scientist, I'm just so appreciative of the work that you're doing, and really appreciate you being here with us today.
Yeah, thank you.
The conversation with Jennifer was so interesting and just fascinating to hear the historical perspective from someone who worked prior to the introduction of GLP-1s for obesity management and dealt with, I would say, insufficient options available to help people manage this chronic condition, which is really complex. And also to hear her talk about all the various factors that sort of go into decision making about what is recommended for people who are hoping to manage this condition of obesity. And one of the things that really stood out to me was that she talked about surgery being kind of one of the only tools that was really evidence-based in the field for years, and sort of this decision-making process of, how sick do people have to be before we recommend this like really intensive approach to managing this condition. I'd love to hear your thoughts. I mean, you've seen this evolution too, and it's just really such a shift now, going from really intensive intervention that we knew worked but had all sorts of downsides, to now this really huge number of options for people to consider and to choose. And so in some ways, obviously it's a good thing for people to have more options, but I imagine it makes the decision much more complex. How have you kind of seen this evolution? Is your perspective on this consistent with what Jennifer described?
Thanks, Emily. I mean, I was struck and still think about just how I personally have evolved. And then I think we've evolved as a society and as a medical group, taking care of people who have overweight or obesity issues. It's a lot to get people to a surgery for obesity. It is a very evidence-based therapy, but really shows us how it was inadequate. People can't all get access to it. People can't all be great candidates for it. And even after they go through it, she highlighted how it's really hard to maintain it or keep all these other things going. So having multiple toolbox items, drugs, therapy, other things is really important. And I thought it was really sort of enlightening to help us understand how it's not just the science of physiology that we're learning, but really how you put these things into practice. Even when you have an effective therapy, like surgical treatment for weight loss or obesity, which does have great data and cardiovascular and other outcomes. One of the thought processes that I thought was just how she's really excited to have other things she can offer her patients.
And it's not the only condition with a lot of social stigma, but it's just been so interesting to see how this has changed, I think, from a really social perspective, that now that we have something to help kind of manage this condition and understand it a lot better with respect to like really how the brain is connected to things like hunger and cravings, and that shows up in this physiologic state that can lead to adverse outcomes. It's just amazing to see it kind of something that we kind of talked about in the shadows now is in the news every day, and is something that people seem much more open to discussing. And I don't know if you've seen that elsewhere in your practice with people who maybe they don't like the identity of being somebody with heart failure or somebody with cardiovascular disease, and that might present a barrier to how they choose, what treatments to pursue or lifestyle or behavioral modifications to pursue. But it's such a powerful factor in this whole treatment decision process. And it was just so interesting to hear her talk about how it's hopefully becoming less stigmatized with time.
Yeah, I think that's right. I mean, as we set up this series, it's been a great first episode to think through this, because I think stigma around obesity is similar sometimes, unfortunately, to the stigma that has lived in our world around mental health issues and does live in our world around some, I'll call it, addiction issues. So they're all in some ways tied to how neurotransmitters in our brain work and how we might respond to things. But, people walking into my clinic who are smoking know that tobacco use isn't beneficial. The problem is it's really hard to stop. And when we got multi-pronged therapies for that, we started to really make a dent, and hopefully we'll continue to do that. And I think that's sort of what we're learning about obesity, in that it's probably going to need multi-pronged things. They're not controllable issues at times. We certainly haven't helped our communities with the kinds of foods we have available. We certainly haven't helped them with the other behavioral kinds of issues that exist. And then there are neurotransmitters or a gut-brain axis where there's receptors that are giving people feedback. And so I think the science is really catching up. I'll just say this will be exciting for us as we go through each of these scenarios, as we today got to hear from Jennifer about surgical therapies and the addition of GLP-1s to that. And Emily, with that, I'll say it's been a really interesting first episode. And as we think through the rest, I just want to tell our audience, thanks for joining us for this episode of Beyond the Endpoint. In our next episode, we'll be speaking with Duke cardiologist Dr. Neha Pagadapati. She'll share how she's seeing the GLP-1's therapeutic impact in her patients' heart health and overall quality of life, and highlight the important research and unanswered questions that still lie ahead in this evolving field. As always, please reach out with your topic recommendations at beyondtheendpoint@duke.edu. Be sure to subscribe to the podcast and connect with the Duke Clinical Research Institute on LinkedIn and at DCRI News on X and Blue Sky.
This has been Beyond the Endpoint. Resources related to this episode are available on dcri.org/BTE. If you have any burning questions about clinical research or healthcare, drop us a line at beyondtheendpoint@duke.edu. We'd love to address your questions in a future episode.